So colleagues, good morning, everyone. For those who do not know me, I am Thiago Eric de Sá. I am the responsible officer for age-friendly environments at the World Health Organization headquarters. And I'll be moderating this session today, where you will have the chance to hear a lot of interesting work done around aging from across the globe. Before we start, I would just like to double check, and please just raise your hand if you have an oral presentation to give today, because I heard that we may have had some issues with visa. So I just want to double check I have everyone in the room. So I know that we have Brent here. Solimar. Okay, so we have Antoni as well. So I guess that we have everyone then, which is excellent. So with no further ado then, I would like to invite to the floor my colleague, Brent, and this is the moment where we start torturing names, and I apologize in advance for mispronouncing. Brent Langellier, and Brent is gonna talk about using systems methods to study neighborhoods in cities as dynamic social systems. Brent, the floor is yours.
Very close.
Yeah, good.
It's a soft G. Cool. Well, I'm Brent Langellier. I'm from Drexel University School of Public Health. Thank you all for coming. I'm excited about this presentation. Cool. So I'm gonna just minimize this. So the long-term goal of this is really to think about how neighborhoods are related to health throughout the life course. And I don't just mean how neighborhoods affect health. I'm sort of thinking broader than that for this, but I think, this is a very sort of generalized framework, but if you think about spatial patterns in health, right? Like, so people have alluded to some of those Robert Wood Johnson projects in the US that show that like in the same city, life expectancy, for example, the biggest of all health outcomes, varies by like up to 20 years, depending on which neighborhood you live in across very short distances. So if you think of those types of patterns in health, not just in life expectancy, but in diabetes or hypertension or COVID or whatever you're interested in, I think sort of fundamentally, those are the product of three sort of interrelated processes. One is residential mobility patterns, or what we might think of as neighborhood self-selection, selection of people into neighborhoods. The other is changes in neighborhood characteristics, right? So we're moving into and out of neighborhoods, but our neighborhoods are changing around us as well, socially, and in terms of the establishments and other assets in them. And then the thing that I think we spend a lot of time on if you're a social epidemiologist or a public health, neighborhoods, urban health researcher, is the contextual effect of the neighborhood characteristics on a person's health. So that's sort of the central hypothesis, is that those three things are important. So I'll talk about each of those. So neighborhood self-selection, all of these are kind of little people in little families with different characteristics, right? And they all sort into neighborhoods, and people obviously sort into different neighborhoods depending on, their own characteristics, their age, their kids, their income, their race, ethnicity in the US, their immigration status, the jobs that they have, right? They all choose or are forced to live in specific neighborhoods. And that's an individual or household level decision. But if you aggregate that up a level, sort of to the city or to the neighborhood level, what you get, at least in the US, is sort of very spatially and socially patterned cities, right? So if you look on the left, this is a dot density map of race ethnicity in Philadelphia, where Drexel is. And you can probably see like the specific colors are not that important, but you can see that this isn't just a sort of randomly allocated city, right? Like we have very stark levels of racial segregation. if you look at poverty as another sort of important social characteristic that determines health, also very tight income segregation. So what you would expect from that, even, you know, absent any contextual effect of neighborhood characteristics on health, is a spatial distribution in health outcomes. That makes sense. That sort of jives with everyone's understanding of these processes. Yeah. Cool. Okay, so this is an individual or household level process. And when people move, it obviously changes their neighborhood exposures, right? But it's also a neighborhood level process because the social composition of neighborhoods is sort of the sum of everyone that's moving in, everyone that's moving out, and then births and deaths that happen, right? So we have this individual level process that aggregates up to a larger sort of spatial patterning in social and health characteristics. And then it's a temporal process as well. So we think of things like air pollution, which came up today, and your cumulative exposure to air pollution throughout the neighborhoods that you've lived in during your lifetime is really important. It's not just this sort of point in time. And then I think another temporal process that's particularly important for aging, especially if you think of sort of older adults and retention of cognitive abilities, is time in their current neighborhood because they develop social ties. They develop ties to places where they can engage in cognitively stimulating activities. So if they move out of those neighborhoods, to some extent, their social ties sort of reset or are at least made more difficult if they move much further away, right? So time in your current neighborhood is also this sort of important temporal process. And then there's this feedback, right? So individual mobility decisions affect the social composition of a neighborhood, which then drives further levels of mobility. And we see this, like in the US context, at least, we see this in, for example, gentrification as an important process. So if I was to make a framework of this, it would be like little people and little families with different characteristics selecting into neighborhoods, and then neighborhoods sort of being different on the right. So that's the first big process. The second is neighborhood change. So people are moving into and out of these neighborhoods. Poverty levels are going up and down. You know, the density of other physical features is going up and down. And then businesses are opening and closing. So like gyms, supermarkets, we talk a lot about food access, right? So supermarkets are opening and closing based on what people are eating, the social characteristics of the neighborhood, and then where other markets are. You know, cities are introducing new parks, new green space, but for the most part, that stuff isn't randomly allocated, right? There is some purposive decision-making, and it might be explicitly about who lives in the neighborhood and what other features are there. So all of this is sort of dynamic and interrelated. So if I think of the things that are really important for older adults living in neighborhoods, you could think of some of the social composition, like how similar I am to other people in my neighborhood and sort of the probability or propensity that I'm going to engage in social activities with other individuals in my neighborhood. But there are also things like establishment density, the neighborhood vibrancy, parks and other green space, walking infrastructure, transit stop density. As older adults sort of lose the ability to drive, transit stop density in particular can be really important. And then things like population density, business and residential vacancy. So I think, you know, I don't want to concentrate on these characteristics per se, but the larger point is that neighborhoods are obviously dynamic, right? Like these things are changing over time in a non-random way. And we should account for that change in our science. So if I were to make another model of this, it would be something like this. So neighborhood social composition is affecting the physical features in a neighborhood, which then feeds back into social composition, because like if a supermarket goes in, you know, some people might be more likely to move into that neighborhood. Social composition is affecting who moves into and out of neighborhoods, right? So that's also interrelated. And then, you know, the number of establishments in a place feeds back into businesses' decisions to open and close, cities' decisions to open parks in that neighborhood. So it's all sort of interrelated in these feedback loops. If I add that to my larger framework, it might look something like this. And then I think the thing that a lot of people are interested in and that we've spent a lot of time on is this contextual effect. So for example, what effect does my food environment, access to food resources have on my health via diet, right? Or what effect does, I think this is a heat map, what effect does heat or access to green space have on my health via stress, via walking behaviors, via those other pathways? And I'm really interested in the social ties that people build over time that are spatially distributed as well. So how does the distance to my friendship network, my family network, for example, impact my health? So my sort of large, silly looking conceptual framework then looks something like this. And you can see that there's arrows kind of going in one direction, which we like to think of, you know, in the context of a regression, for example, most of the arrows going one way. But I think the larger thing is that some of these arrows go back, right? Many of these are feedback loops, and we should use methods to conceptualize and to study these feedback loops. That's where I think complex systems thinking comes in. So we can use dynamic conceptual models. This is just a quick causal loop diagram that features some of those feedback loops that I just described in a sort of more formal way. But we can also use simulation methods, some of the methods that have been talked about previously in the conference. And I think the important thing to think about is that these are not like a replacement for sort of your standard epi methods, but they're a complement. So we focus on feedback loops. We can focus on different types of autonomous actors. So individuals that make decisions about where to live, businesses about where to open and close, policymakers about what policies to pass. We can look at interactions and dependencies between humans and their environments or different environmental features. And we can look at things over time like temporal change and cumulative exposure. And so these are really complementary questions. You know, I think the standard epi methods are really 2 minutes on it. Sort of what is the independent effect of X neighborhood characteristic on Y health or social outcome, net of confounders. We're really focusing a lot of our sort of research resources intellectually and financially on estimating that Y on X. And that's super important, but it's not the only question, right? So I think, you know, some of these questions are like, how are neighborhoods functioning as systems? How do people select into neighborhoods? How do individual level mobility decisions aggregate up to neighborhood change? And then how do other actors respond to those changing neighborhoods? How do these contextual effects work in combination? You know, if you introduce a change into a neighborhood that you think is like a underprivileged, minoritized, marginalized neighborhood, if you introduce an awesome new supermarket and then it forces different type of people to move into that neighborhood and sort of push the longstanding residents out, have you really made, you know, an equitable change? Have you sort of made the policy gains that you're hoping for? Probably not. We should consider those dynamics when we're thinking about policy, I would say. We can also ask very explicit questions about how policies can be used for equity. How can they be combined? How can they be spatially or socially targeted? What are the intended and unintended consequences? We can ask questions about the overall structure and function of a system, like are there important feedback loops? How do stakeholders view the role of neighborhoods in changing and shaping health? And then we can also make our research better. I think we can use systems methods to sort of better conceptualize neighborhoods as dynamic systems, and then use that knowledge to guide our decisions about what data to collect, longitudinal versus cross-sectional studies, what environmental data we need to collect, right? So I think that research feedbacks are really important as well. And that was like exactly 2 minutes, so I feel amazing. Thank you.
That's excellent, Brent. We saw that it's always easier to study things that are not moving, but we know that neighborhoods are not like that. Do we have any burning question for Brent? Let's take questions first before, just to make sure that we have a more interactive conversation here. Do we have any questions for Brent now? But in this case, if not, I suggest we pass to Antoni, and then we have a conversation in the end with all the speakers. Antoni, please.
So thank you. I'm Antoni from the Instituto de Biotecnología de Málaga. Good morning, everyone. I'm pleased to present today the first results from a longitudinal and multicentric study in Spain about the interaction between the PREDIMET study, its field trial intervention, and the environment in which its participants live. This project is part of the PREDIMET Plus network, and it has been possible thanks to a big group of researchers from several universities and institutions. So as this portrait of Van Gogh transmits to us, people are usually more concerned about the problems of aging than exciting about its benefits. But beyond the individual determinants, we will see how the environment in which we age can make us more active. But first of all, we need to point out why is an active aging a key public health issue. So on the one hand, we can see the rapid increase in the population of older people globally, led by Europe in blue, and its predictions for the next 30 years. On the other hand, in the following graph, we can see that the elderly represents the most inactive population across regions. Both women and men become less active as they get older. Also, we know that insufficient physical activity is responsible for a significant percentage of cancers, diabetes, and heart disease. Only in the European region, it is attributed 10% of the total deaths per year. So this rapid increase in older people and the growing trend of insufficient physical activity, together with its consequence for health, means that we have a public health bomb in our hands. So globally and locally, we must look for the best evidence which can we use to advocate, inform, and lead physical activity policy. But this recent report serves as a declaration, call for a stronger collective action to close the gap in policy implementation and to advocate for accelerate political actions. In this context, the PREDIMET Plus study team proposed a trial to test an intensive lifestyle intervention. Participants recruited from primary health care centers are obese or overweighted older adults, which have at least 3 criteria for the metabolic syndrome, but without cardiovascular disease. The full protocol of the trial is available on the website, predimetplus.com, and the core design is recently published. During the trial, participants in the intervention group are receiving an intensive intervention with an hypocaloric Mediterranean diet and physical activity supported by behavioral therapy, with the aim of achieving sustainable weight loss. Comparably, participants in the control group are receiving a less intensive intervention, only with advice on Mediterranean diet, without physical activity and without hypocaloric diet. Oh, sorry. The ultimate goal of the PREDIMED Plus study is to demonstrate the impact of this intensive weight loss intervention on the prevention of cardiovascular disease compared to the control group. Although the study is currently underway, its recently published results show promising effectiveness after 12 months in the weight loss and a significant increase in physical activity in the intervention group. Depending on long-term results from the PREDIMED Plus, other individual interventions, although they may have short-term effects, tend to be ineffective in long term. In addition, people's response to this weight loss intervention can vary variably, considerably. No? So what factors can contribute to these variations in people's success during the weight loss interventions? There is no doubt, as we can see that there is a potential contribution of a variability of biological, behavioral, and psychological factors. Even so, the current conceptual models of healthy behavior acquisition suggests that interrelationships between individual factors and environmental factors should be observed in the course of the acquisition healthy behaviors. Sorry. And I take advantage of this graffiti to highlight the importance of environments as a determinant in health-related habitat acquisitions, since we tragically we have designed cities that make acquisition of health habits unpleasant, unsafe, even sometimes impossible for some people. With this in our minds, on a sample or subsample of the participants recruited in 8 PREDIMED Plus centers, we propose a longitudinal multicentric study with an analytical sample around 2,000 participants living in urban areas and recruited for 55 primary healthcare centers. So after geocode these participants, we calculate an area of influence from their residents using a pedestrian network, creating these kind of Saussure buffers. From each street network buffers, we extracted features for the neighborhood walkability. Each measure was normalized using set scores, and walkability index was calculated by assuming each set score. Outcome variable in the presented study, physical activity, was measured at baseline and the 3 follow-ups, visit 6 months and 12 months and 24 months of the study baseline. Time dedicated to performing moderate vigorous intensity physical activity was obtained through accelerometry using the other tools cutoff points. Sorry. Finally, statistical analysis. We applied generalized additive mixed models in which random effects were included in the linear predictor to take account of the clustering effect at the participant level, multiple observation, and nested in the census area. In addition, this design, we examined the interaction and apply a stratified analysis for the study condition, I mean intervention group with physical activity and control group without physical activity intervention. And as we can see in the table, walkability in general does not seem to favor physical activity or taking account all the participants, although analyses were stratified by intervention, and they only show a significant increase at the physical activity in the intervention group. And we are currently analyzing the association of food environment and the changes in eating behavior during the intervention and this association with BMI changes. And to finish, I will do special thanks to the Baleares Son Espaces Center and the Malaga Costa del Sol Center, of course, to all other recruiting centers, especially all the funding entities that make it possible to contribute in this line of research. And finally, I would like to thank especially every one of the participants of the Predimed Plus study. Here some of the, in the picture, some of the Son Espaces, but extend to all the recruitment centers. And this is all. I'm on your disposal to answer your questions and comments. And if not, I have my email here. You can send me an email. So thank you.
Thank you, Antoni. No, it's fascinating to see an intervention, tracking physical activity for the people with a long follow-up period, which is unusual, and already accounted for the dynamic dimensions of neighborhoods. Antoni, thank you very much.
Thank you.
I think we will pass to the next presenters and collect the questions in the end.
Thank you.
So next, I have, and apologies in advance for mispronouncing the name, I have Heng-Yun Ko, that will be talking about applying the 15-minute city concept in an aging society, case study in Taiwan.
Okay. Good morning, everyone. Thank you for being here. I'm Heng-Yun, a graduate student from the Department of Urban Planning, National Cheng Kung University in Taiwan. Today, I'm going to show my research with you. My topic is applying the 15-minute city concept in an aging society, a case study in Taiwan. Okay. Before today's presentation, I would like to ask a question. Do everyone know about 15-minute city concept? In my opinion, the 15-minute city concept is a coronal urbanism model, and it has a various explanation based on different country goals. For example, Denmark is a 5-minute city. Its public transportations can be reached by walking and arrive different places easily. Both Shanghai and Paris implement 15-minute city concept, but they have different aims and ways. In Paris, walking and cycling are encouraged to arrive daily requirement place. But in Shanghai, they want to improve residents' health by walking, so they implement 15-minute neighborhood planning. To sum up, we can say that 15-minute city is not only a low-carbon lifestyle, but also a model of life facing the COVID-19. The 15-minute city can achieve many various. And it also has a key concept of inclusivity, which I think that has many same features with aging in place. They both can study people's daily needs to meet the expected visions. However, urban planning mostly use general situation thinking, but that's considered in elderly, like density, road network, land use, lifestyle. And white mat, Taiwan needs a 15-minute city. Taiwan has a very high pollution density and urbanization degree. However, urban area only occupy 13% of land. Over 79% of people live in urban area. Also, Taiwan entered an aging society in 2018. The proportion of people aged over 65 will reach 20% of the total pollutions by 2026, which means 1 out of 5 is elderly in Taiwan. Moreover, Taiwan has the highest density of scooters in the world. The population is 23 million in Taiwan, but there are 14 million scooters and 8.4 million cars. These photos are the street image in Taiwan. Scooter gatherings are like a waterfall. This situation causes serious air pollution and carbon emissions. Taiwan's planning strategies is called originality and look for people-oriented design, which affects resident quality of life. Taiwan is a mixed land use place. For our living area, there may be a convenience store downstairs for my home and a restaurant next to it, a bank around the corner. These of them make us think about put 15-minute cities into practice and then hope to reduce the cars and the scooters, fulfill the requirements in daily life by working. Taiwan urban development patterns are characterized by high density, high accessibility, and mixed land use, similar to the fourth frameworks of the 15-minute city model: density, proximity, diversity, and digitalization. And if you want to promote the 15-minute city, how to evolve with the aging trade and meet the aging in place goal will be on urgent issues. How to localize the 15-minute city concept in Taiwan? The following factors must be considered. First is working ability. Taiwan is a tropical country. Summer temperature in Taiwan can reach 42 degrees Celsius. It's uncomfortable to work too long on the road. The most ideal working time is less than 10 minutes. The most ideal working distance is within 800 meters. Second, facility needs. There are 6 items on the basis of Taiwan's research, such as daily living, life survives, sport and leisure, medical and health care, situations and disaster prevention, and transport. Third, consider different pollution structure. Aging in place is currently Taiwan national long-term care policies. The elder will be the main user in the city. According to Taiwan research, elderly-friendly working situation, working time is less than 5 minutes, working degrees within 500 meters. And this study area chose Taiwan Chiayi City. It is because Chiayi City is one of only 2 cities with an entire area for urban planning. Although small in size, it has a well-developed living function. And Chiayi City is the first age-friendly model city in Taiwan. The government department aims to create a city where all generation can share the passive. And it is my math. First, defining of working ability. Second, definite of facility needs. Third, use ArcGIS span facility buffer to assessing the accessibility of function survivors. When a working degrees in within 800 meters, most community can fulfill the 6 type of facility. And when limit the working distance to 500 meters, most locations still fulfill daily needs. Although Chiayi City can satisfy the requirements of 5-minute city, when we consider other factors, does it help the condition of the elderly. The elderly are highly variable, and their mobility will drop immediately within a few days. Therefore, the scoper needs to be retraced. And I said the elderly can walk 200 meters when they are slightly in governments. Our elderly are high heterogeneous, and we need to consider them the most valuable perspective. When the elderly health is good enough to work, it is necessary to discuss more, create a sustainable aging environment. Increasing the willingness to work is based on the working environment in the city. However, Taiwan's sidewalks are always narrow, discontinuous, and have high difference. Most of the sidewalk will also become a parking space. This situation causes a very unfriendly environment for the elderly. If a city needs to be a better place, they need to consider all the residents. In Taiwan, there is still a long way to go when creating a city that implements a 15-minute city, fulfill the needs of the elderly. When we think a bit more, those services need to be available to the disabled elderly. Nowadays, it is possible to more safely and smoothly even in a wheelchair. Both were my currently present research ideas. There are still many areas for promoting and cautious. The demand of facility is most based on service by government departments. But if I really want to deep into the local area, I have to conduct interview with the local area through questionnaires. The following on discussion about the user experience and actual situation. I will complete the research in my master thesis. This is my end of my presentation, and thank you for your attention. If you have any achieve or opinion, we can discuss it after the sessions.
Yes. Excellent, very interesting. We went from an educational approach to a land use transport approach on how to make people's lives a better place. And in this case, all the people in the two numbers. So now we're going to jump to the other side of how to live it. So we're going to talk about the COVID-19 hospitalization and the profile and the spatial distribution in Belo Horizonte, Brazil. So Solimar Rocha is the project.
So hello, everyone. Thank you very much for being here. My name is Solimar. I'm a geographer, and I work in the Zubi, the Observatory for Urban Health in Belo Horizonte. And today I'll be presenting the work COVID-19 hospitalizations among youth, profile, and spatial distribution in Belo Horizonte, Brazil. So first of all, I'd like to thank the group of authors. This is a collective work, which I'm representing here. And in our city, Belo Horizonte, we have seen that children and adolescents had the lowest proportion of hospitalizations among all age groups throughout the COVID-19 pandemic, which in our city was decreed in March the 18th of 2020. However, in the year of 2021, their representativeness increased very much and this demands better understanding of the process. So just to give you some context, this study is nested within the OZUBI InfoCovid, which is a bulletin that tracks the spatial distribution of severe cases and deaths reported by COVID-19 in Belo Horizonte since the beginning of the pandemic. We have had 16 editions so far, and this bulletin is available publicly through this QR code or the Faculdade de Medicina website from the Federal University of Minas Gerais. So here we are in the southeast of Brazil, and we are the capital of the state of Minas Gerais. And this study has the purpose to investigate the profile and the spatial distribution of SARS-CoV-2 and unspecified SARS hospitalization among children and adolescents in a big city in Brazil. So for that, we used data on COVID-19 hospitalizations, which were geocoded by our research group and were obtained through an important intersectoral partnership with the City Health Department. The descriptive analysis included the profile of all SARS-CoV-2 and unspecified SARS hospitalization among 0 to 19 years old. And for the spatial distribution, we considered the age group from 0 to 11 years old because this group had not yet been contemplated by the immunization national plan in our country. And then the kernel density maps were made based on residential address of each patient. We geocoded about 98%. And the comparisons were made with the overall hospitalized population. Okay, so as a result, we have that from January 2020 to January 2022, the Belo Horizonte City Health Department has registered almost 60,000 hospitalization cases. And among them, more than 4,500 occurred in the age group between 0 to 19 years old, and more than 4,000 between 0 to 11 years old. And in all the age groups, the number of hospitalizations were higher in 2021 than 2020. But as we can see in this graph, the percentage change was much higher among children and adolescents than adults. And I don't know if I can show you in the graph. Okay. Sorry. Can you see? Okay, so this is from the beginning of 2020, and this is the end of 2020, and then from 2021 to the end of 2021, we can see that at the end of the year of 2021, the number of cases in children and adolescents reached about 25% of the cases. And then for the spatial distribution, we can see that in general, the hotspots, which are in red, are the most where the most it's most dense in cases. They correspond in both cases. In this side, the children, and this side the total population. But among children, it's much more concentrated, and slums. And as you can see in this close-up satellite image, which is Aglomerado da Serra, which is the biggest slum in our city, we can see that the hotspot happens precisely in the slum area, and then the density goes lower as we go to the formal city. So just some final remarks about this work. We highlight the impact of living in the city's most vulnerable areas, especially for the urban children and adolescents, for severe cases and mortality of COVID-19. And we argue that the observed growing and sustained tendency of the proportional increase in the hospitalizations of children could be the result of the effective preventive actions on severe cases only taking place among adults until the end of 2021, because they were the only one vaccinated so far. And our results suggest a compelling need to broadly stimulate COVID-19 vaccination, especially in the city's most vulnerable areas, with information campaigns. And this could contribute to containing the virus from spreading and strengthening group immunity, and thus protecting our children, and also to expand epidemiological surveillance. And just to finish some updates, because we did this work in the beginning of 2022, and then vaccination on children started in 2022, but it started very late compared to many other countries, and has been very slow, surrounded by controversies generated by the spread of fake news, despite the widely available evidence in its favor, also with other vaccines. And just to give you a context, in Belo Horizonte, the first dose for children started in January for the age of 11, and it's still happening. And the coverage for 5 to 11 years old is 86% for the first dose and 64% for the second dose. And the children aged from 3 to 4 years old only took the first dose, and only 21% of them so far. Okay, I'd like to thank you for your attention, and for ISUH for sponsoring my me being here through the ACE project. And thank you very much.
It's thanks to works like this that we can advance public health in such a global crisis. So if you haven't vaccinated your children or yourself, please do so. I would like, Solimar, please stay. I would like to invite the colleagues to actually join our panel. Antoni, Brent, our student. Sorry, I'm really sorry. I'm really sorry, colleagues. I have an outdated version here. We have Eric now coming from Uganda, who is also going to talk about immunization and the role of private sector in this. Eric, please.
Hello, everyone. I'm Eric Seguja, and I'll be presenting about reactivation of the private sector to transform urban immunization service delivery in Kampala City, Uganda. We're looking at the lessons we learned and the implementation experiences. Okay. Oh, okay. Yeah, I'd like to acknowledge the team members that we've worked with on this project, and they represent different institutions. First is the City Health Authorities, the School of Public Health, Makerere University, and the Ministry of Health of Uganda. The role of immunization in protecting children and improving their well-being in later life is acknowledged through different publications that reflect its effectiveness, but also looking at the cost it takes and the benefits that come with it are also very much documented. But when you look at its delivery, there are many challenges that some originate from the quality of data that should ideally inform the evidence-based planning to improve delivery of immunization services, more so in the urban context, which is dominated by the private for-profit, especially the lower level private for-profit sector, which doesn't require that much capital investment to deliver such services. Within the urban context, there are contextual challenges arising from the inadequate resources, more so when you look at the lower level of service provision. Data quality becomes a second priority compared to the things that would resonate well with the profit maximization, resource allocation, and being able to survive within a competitive implementation context. When you look at delivery of immunization services, there are costs that are meant to be incurred by the private sector. And yet the national policies and guidelines dictate that the private sector receives free vaccines from the ministry in anticipation that they will also deliver these services free of charge. So it creates a complex situation for such actors to be expected to deliver services, yet where they deliver those services from, perhaps they rent the premises, but they also have to pay human resource. And there are also other invisible relationships that pretty much determine how they deliver these services, especially the regulatory. When you look at their relationship with the city authorities, the regulatory environment, it may not be visible, but it's more of enforcing the regulations. So those are some of the underlying factors. So we worked on a project that was aiming at improving service delivery among the private sector, more so looking at the quality. Our entry point was the quality of data so that it can be used to inform evidence-based planning to improve the overall service delivery in the urban context. So we co-designed with actors, major actors in the delivery of urban immunization services, data quality improvement intervention among the lower level. We focused on the lower levels because they constitute up to 95% of immunization service delivery. To put it in context, we also have the higher level corporate hospitals. They also do some work, but the task is predominantly with these lower level clinics and lower level service providers. So I'm here to present on behalf of the team, the early implementation, what is it that we saw? Ideally, this was a quasi-experimental mixed methods approach we implemented in Kampala, and we prioritized. Kampala has administrative divisions, and we prioritized those divisions that were poorly performing in terms of immunization service delivery. We went for the lower levels I've already mentioned, and we identified the 40 overall, but 20 in the intervention and the 20 in the control arm. So this was the outlook during the last half of 2021, which informed our intervention. Above other divisions, Kawempe division, Makinde division, Nakawa division, and Vaga division. And when you look, it was mostly in Makinde and Nakawa division, but this is the industrial division. So we don't have huge resident population. So we decided to replace it with this. Most of the population that are utilizing services are migrant workers that come to do work, but reside outside the city. Okay, yeah, the indicators that we prioritized to assess whether we had done something were DPT1 coverage, DPT3, and the MR, and fully vaccinated. Then for the qualitative, we interrogated the experiences of the implementers and best practices and lessons learned. One of the things that we learned from implementing this was that there were variations in immunization schedules leading to loss of data after capture. There is the standard schedule that is recommended by the ministry, but within the private sector, you find that a very small private provider prioritizes more of international vaccines because that's what the market, the demand that is available dictates, and they tend to overlook the nationally recommended vaccination schedule. So they will capture that data, but it will not end up in the data systems of the Ministry of Health. So data is there, but not utilized. Otherwise, if it was utilized, they would know where the demand is and the shortfalls are, then to plan appropriately to deliver adequate services. Then when it comes to the data systems, we realize that the private sector, some of the private actors had prioritized the data and they had gone electronic, yet the national system was still lagging behind. Where they have gone electronic, still they at data capture, they do manual. And that also led to loss of data, which would initially be captured, but somehow it doesn't get to inform evidence-based planning. Then the reporting arrangement. The private sector also had other partners that were supporting the delivery of immunization services. But when you look at their priorities, some were after utilization, others were after generating administrative data. Then there were challenges in capacities to deliver services, where there was a very high staff turnover witnessed in many of the lower level private providers, which impacted on the skills to improve immunization services. As I conclude, we also observed that low priority was given to data, and more so originating from the priority that was accorded to immunization, because they were not expected to earn, so they prioritized those services that were getting them, generating them income. Then during the co-creation, it was revealed that peer learning was a very important aspect for self-improvement, starting with different private providers, not necessarily the city regulators, but the different providers. Then prompt feedback and support supervision and continuous reminders also contributed to improvements. As I conclude, when you look at the private sector and delivery of immunization services, it's a complex situation within the urban setting. There are some factors that are attributed to the nature of the work that they do and the context in which they deliver these services, but also other factors have a lot to do with the kind of human resource that they deploy and the safety and security of tenure that affects the skills retained. Then there are other factors that are predominantly data system related factors. I would like to acknowledge the different entities that supported this work, and lastly, the International Society for Urban Health that facilitated my coming here and being able to talk to you the experiences that we've learned from implementing this project in Uganda. Thanks so much.
Thank you, Eric, and it's very interesting to see these comparative examples, learning from the private and the public sector. And it's fascinating to see also the work coming from Uganda. And Eric, I think that there's a reason why you're not in my program, which is older. It's because we needed a representative from Africa here. Unfortunately, we are running out of time, but I would just like to ask the presenters to stand. Solimar, Ko, Brent, Antoni. And I would like us to acknowledge the outstanding contribution coming from the US, Spain, Kenya, Taiwan, and Brazil. So I invite you all to interact with them, to exchange bilaterally. If you have any questions now, I would kindly ask you to ask them, and we can have an open conversation. Otherwise, we can take it bilaterally afterwards. Do we have any questions? One or two questions that you would like to ask to the colleagues? Yes, Felipa.
I'm going to concentrate on the walking one. I thought it was interesting the distinguishing the 15-minute city and also trying to get the old people walking. That early evidence that people will walk if they go and see a tree that's in blossom or that's the favorite part of town did you build in some features that people particularly like, maybe the house where they grew up or some things, to make it more interesting for people? Because you could walk on the spot for 15 minutes and that mightn't be as reinforcing as knowing that you were going to meet people.
So is the question direct?
The question is, well, both of one is that older people were encouraged to walk, but we didn't know where or what was the, what did they set the course, or could they just go anywhere? And then the other question about 15 minutes, but you could go around a roundabout. So, and I'm saying it's more reinforcing for people if there's something that a part of the city that they really like or something, and whether you build that in.
Right, so
I just wondered if they were doing it.
Antoni, would you like to respond?
Yeah, well, I think it's awesome that people, I mean, if you recommend people or other people to walk, they need to be surrounded by green spaces or surrounding of high walkability neighborhoods, because if not, you are also creating health inequalities. No, only the people who have these kind of surroundings can improve their work.
So please do exchange bilaterally after this chat. Is there any other question, colleagues, that you would like to ask to our panelists? Yes, we have another one there.
Yes, hello, I'm Hanneke Kruijsen from the Netherlands, and I have a question for the first speaker about the system dynamics model. I was curious that if it has been applied already, because we are working on the same topic, and we are really interested how to feed it also with data and the simulation part.
So the aging one has not been applied, but we have a couple examples of models. So we have conceptual models that were built sort of via stakeholder engagement in projects in Latin America that are related to diet, sort of food environment, as well as transport, and then in Philadelphia related to diet disparities, which sort of widened into larger like racism and social disparities. And then we have age-based models in Latin America that are related to kind of those two things. So there's a transport model based in Bogota, and then like a synthetic Bogota, and then use Mexican data for some food modeling related to interesting food policies, and then also kind of the greenhouse gas emissions associated with all stages of the life cycle of food. And we have not developed with Philadelphia. So we're in various stages kind of with these projects, but I'm happy to talk after.
Any more questions, colleagues? Felipa.
I've just been looking at with Carlos Saldiva in Sao Paulo about the rates, and is there any reason why the rates have been suddenly going up in 2022? And is that the children aspect of the children, or is that across the board?
So some hypotheses that we have are that children weren't vaccinated in 2021, and the adults were. Children were only vaccinated in 2022 this year, and still it's a low coverage. And also the classes restarted in August 2021 when children were not vaccinated. So maybe we haven't checked to see if it's really the reason, but it's some hypothesis. I'm not sure if I answered you. Yeah, and also in 2020, there was much more underreported cases because tests were very scarce and expensive, and the municipality wasn't offering them yet. They started doing this last year. And so although we have the database directly from the city health department, it was a new disease, and the municipality had its challenges.
Maybe just a very quick follow-up question to Eric. Eric, is it so? How's the situation now on COVID, also in terms of children vaccination in Uganda? Could you share with us? Is the situation similar to the one we see in Brazil? Is different?
It's not pretty much different. You know, during the lockdown, there was a total blackout on mobility, and that pretty much affected. But like what she has presented, a lot of misinformation is going around, so the response from the community and the public is pretty much the same. Suspicion around the efficacy and the intentions.
Thank you, Eric. Thank you all the speakers. It was an excellent session. I do thank you all for attending and contributing. Apologies in advance, we're slightly behind schedule, but I would really like to ask you to join me in a big round of applause to all our distinguished speakers today. And please do make sure to follow up bilaterally with them as well. Thank you.